In the past, the use of multifocal IOLs in astigmatic eyes has required the application of additional refractive procedures, such as limbal relaxing incisions or laser corneal surgery. Higher levels of astigmatism could not be corrected by incisional techniques in a reliable and reproducible way. Therefore, the number of patients who could benefit from multifocal IOLs was limited. The acrylaser torique IOL is the combination of the high-performance optic of a multifocal IOL and the reliable astigmatism correction of a torique IOL on a microincision IOL platform. This IOL gives a chance to many of our presbyopic or regular cataract patients with astigmatism to enjoy life with only minimal or no support from glasses. Designed as a single piece, diffractive torique lens, the acrylaser torique can be injected through a 1.5mm incision. The cylinder can be corrected from +1 to +12 diopters. The acrylaser torique is custom made. Each lens is calculated and manufactured individually for every patient to provide the optimal post-op refractive results. A coaxial microincision prelec surgery is going to be performed on an active 56-year-old patient through a 1.7mm incision. The pre-op refraction of the patient was +5 sphere with a +3.5 cylinder at 95 degrees. Correction of pre-existing astigmatism, even as low as 1 diopter, is a key of success for the implantation of a multifocal IOL. Accurate corneal topography and optical biometry are mandatory to rule out any relevant corneal pathologies, high coma levels, or against the rule astigmatism. They also allow the precise determination of the axis of astigmatism to be corrected. The chosen acrylaser torique lens power was with a sphere of +27.5 OD and a cylinder of +3.5 OD. Even with such a high power, the lens can still be injected through a sub 2mm incision. Use of a specific marker is required to mark the horizontal axis of the cornea. For the marking, the patient is sitting in the upright position. Coaxial microincision cataract surgery has several safety advantages associated with an almost immediate visual recovery and a rapid wound healing for our patients. But this procedure requires a microincision IOL, which would ideally be a thin IOL able to be rolled up small enough, injected below 2mm, while retaining enough power for a wide range of patients, offering stability and centration and an optimized optic design for a good visual outcome. Co-mix surgery allows safe removal of the lens through a single sub 2mm microincision. A single microincision is neutral on corneal cylinder regardless of the incision site and of the pre-op astigmatism. All surgical maneuvers are performed through this single microincision and require few but specific instruments. After performing a hydrodissection, the coaxial microincision phacoemulsification procedure starts. Co-mix surgery provides an excellent predictability in terms of refractive outcome and astigmatic neutrality. It has a smooth fluidics and phacodynamics to prevent any intraoperative leakage, while providing an excellent operative view without having to change one's technique. Moreover, the anterior chamber remains stable throughout the entire procedure time, as less energy is released into it. A diffractive refractive microstructure covers the complete optical 6mm diameter of the acrylaser torique IOL. As a consequence, the optical performance of the lens is independent from pupil size. Two marks located on the upper left and bottom right of the haptics identify the correct lens position upside up. Two holes and lines at the border of the optic show the flat curvature axis of the lens and allow the alignment of the lens precisely with the steeper corneal meridian intra-ob thanks to a micro-manipulator. The specifically designed micro-incision single-use cartridge and injector are used for a safe injection of the lens into the capsular bag. Just before the injection, the IOL is gently pushed in the tip of the cartridge. The highly compressible material of the lens allows implantation through 1.7 mm without having to enlarge the microincision. For a maximum precision in the IOL alignment, a screen transparency indicating the steeper corneal meridian of each patient is used on a monitor. The differential topography map shows that the comb mix procedure performed through 1.7 mm didn't surgically induce any astigmatism. Absence of post-op astigmatism, combined with the ultra-precise corneal topography and optical biometry, significantly improves the visual outcomes of the latest generation of innovative diffractive optics.